Welcome back, our fans. 3. Necrotizing periodontal diseases. A group of conditions that share a characteristic phenotype where necrosis of the gingival or periodontal tissues is a prominent feature. Necrotizing periodontal diseases. NG. NP. NS. A. Necrotizing gingivitis is a microbial disease of the gingiva with impaired host response. Clinical picture. A nonspecific acute inflammatory process. Onset, sudden. Course, recurrent. Ulceration and necrosis of the interdental papillae extend to marginal gingiva, rare to attached gingiva. Punched out crater-like depression. Recession rather than pocket formation. Gray pseudomembrane slough covers crater. Linear erythema demarcates pseudomembrane from remainder of gingival mucosa. Gingival bleeding spontaneous or with stimulation. Foul odor. Bad metallic taste due to blood decomposition. Increased salivation. Radiating and gnawing pain. Regional lymphadenopathy and fever in moderate cases. In severe cases, high fever, palpitation, leukocytosis. Etiology. The specific cause of NG has not been established, and it is produced by a complex of bacterial organisms but requires underlying tissue changes to facilitate the pathogenic activity of the bacteria. Microbiology. Spirochetes, Treponema pallidum, invade underlying tissues. Fusiform bacilli. Local predisposing factors of NG. Pre-existing gingivitis. Pre-existing periodontitis, paracoronal flaps, favorable environment for anaerobic fusiform bacilli and spirochetes. Local trauma by malocclusion. Smoking. 98% of NG patients are smoker. Systemic predisposing factors. 1. Nutritional deficiency, VEAT. 2. Debilitating disease. 3. Psychosomatic factors. Disease often occurs in association with stressful situations. Diagnosis. Based on clinical findings of pain, necrosis and bleeding. DD. Small black square, acute herpetic gingivostomatitis. Small black square, desquamative gingivitis. Small black square, streptococcal gingivostomatitis. Agranulocytosis. Small black square, diphtheria. Comprehensive medical history. Recent illness. Change in living habits. Long time work without adequate rest. Dietary background. Cigarette smoking. HIV. Psychosocial parameters, for example, stress, depression. Treatment of NG. Isolate the area with cotton rolls and dried. A topical anesthetic is applied. After 2 or 3 minutes, the areas are gently swabbed with a moistened cotton pellet to remove the pseudomembrane and non-attached surface debris. Bleeding may be profuse. Each cotton pellet is used in a small area, and then discarded. The superficial calculus is removed by. Subgingival scaling and debridement are contraindicated at this time because these procedures may postpone any other TTT other than emergency for 4 weeks. Patients with moderate or severe NUG and local lymphadenopathy or other systemic signs or symptoms are placed on an antibiotic regimen. For amoxicillin-sensitive patients, erythromycin 500 mg every 6 hours for 7 days. Or metronidazole 500 mg every 12 hours for 7 days. Amoxicillin 500 mg orally every 6 hours for 10 days. The patient is discharged with the following instructions. 1. Avoid tobacco, alcohol, and condiments. 2. Rinse with a glass full of an equal mixture of 3% hydrogen peroxide and warm water every 2 hours and or twice daily with 0.12% chlorhexidine solution. 3. An analgesic, such as a nonsteroidal anti-inflammatory drug. 4. Adequate rest and avoid exposure to sun. 5. Re-evaluation after 1 to 2 days. Small black square, 1 or 2 days after the first visit. Small black square, the patient's condition is usually improved. Small black square, the pain is diminished or no longer present. Small black square, the gingival margins are erythematous, but without a superficial pseudomembrane. Small black square, scaling is performed if needed. Small black square, the instructions to the patient are the same as those given previously. 5 days after the second visit. The patient essentially symptom-free. Some erythema may still be present. SRP is repeated if necessary. The patient is instructed in plaque control procedures. The hydrogen peroxide rinses are discontinued. Chlorhexidine rinses can be maintained for 2 or 3 weeks. The patient should be re-evaluated at 1 month for management of residual conditions. Any gingival deformity corrected by gingivectomy after 4 to 6 weeks. Necrotizing periodontitis. Necrosis extend to the deep interdental crater. In severe cases, bone sequestrum. Tooth mobility and loss. Predisposing factors of NP. Immunocompromised PT. Stress. Malnutrition that impair host response. Prognosis of NG. Noma and gangrenous stomatitis. Necrotizing gingivitis may progress to a fulminating orofacial infection called noma. Noma may develop when the initial gingival necrosis progresses to a necrotizing periodontitis and thereafter to necrotizing stomatitis when the infection spreads to other soft tissues and the bone. It is often lethal, and it affects mainly malnourished children or otherwise compromised patients. Treatment can be initiated by local debridement of lesions with SRP using local anesthesia to reduce pain. The use of ultrasonic instrumentation with profuse irrigation may enhance debridement and flushing of the deep lesions. Instructions for good oral hygiene. Antimicrobial as CHX is helpful. Use of systemic antibiotic and analgesics. 250 mg, with 2 tablets taken immediately and then 2 tablets taken 4 times daily for 5 to 7 days. Use of antifungal as prophylaxis. References. 1. Carranza's Clinical Periodontology 13th edition 2018. Essentials of Periodontology. 2. A new classification scheme for periodontal and peri-implant. Diseases and conditions, introduction and key changes from the 1999 classification. Jack G. Caton 1, Gary Armitage 2, Tord Berglund 3, Ian L. C. Chappell 4. Sir N. Jepson 5, Kenneth S. Kornman 6, Brian L. Mealy 7, Panos N. Papapanu 8. Mariano Sans 9, Maurizio S. Finetti 10. Thanks for watching. Support us by likes and subscribes.